Hello, good afternoon, dear ladies and gentlemen, dear friends and colleagues. Welcome from Vienna to our global broadcast about the latest news of implantable hearing aids. I'm very happy to share these wonderful people with all of you here in the warm northern summer. So we have interesting topics in the hearing group, and I really want to welcome you for this wonderful session. The hearing group was founded in 2008, so some years ago, by experts and leading people in the field of otology. And it's a big honor for me to chair this group now for 3 years. You see, it's a wide, broad bench of people, young one, older one, more experienced ones, very experienced ones. We're a global network of 31 centers, and all together we cover the experience of some 100,000 implantations. So this is really quite a number, and we want to share these enormous implant experience and patient experience with you to find out the latest news, the latest profit for you in your daily life. We are here to set the standards since 13 years. We have a lot of publications you will find in the hearing, on the hearing homepage, and also in the literature. We try to be innovative with new surgical concepts, comprehensive, coming together and featuring new ideas and making new studies and new experiences to educate younger colleagues or colleagues who are new in the field, also students who are especially interested in otology or implantology. And we work together in studies all over the world, and also to help to find new implant centers or new otology centers to bring this wonderful world of hearing to the people. Now for this, please mute your microphone and do not forget to raise your hand if you want to talk to us. And please name yourself that we have an idea whom we are talking with. This is very, very kind, and we are very happy to have now quite some experience. Just at the end, the meeting will be recorded as all the other meetings. You will find the recent meetings from the last 1.5 years since the COVID crisis. We started that. You will find all these meetings edited on YouTube. Today, we have a very nice program, middle ear and bone conduction implants, and we have a wonderful panel with Professor Luis Lazaleta, PhD Roberto Marina from Perth, a very experienced surgeon, Professor Georg Sprinzel, also here from Austria, just near Vienna at the University Clinic of St. Pölten, Professor Javier Gavilan from the University La Paz in Madrid, very experienced. He wrote 8 books already, and myself, one of the guys who is in this topic since the very beginning, now for 30 years. And now I want to introduce our wonderful moderator from Madrid and good friend, Professor Javier Gavilan. He has over 360 papers in the Medline, and I think he is a very good person to bring us through this journey. Have a lot of fun with us, and I hope you can enjoy it. Thank you very much.
Thank you for being here. I was telling hello to Professor Baumgartner and to all of you. We have right now more than 100 people at the other side of the camera. And I was trying to make of this a very practical session. The lack of personal interaction in these pandemic times allows us to make efforts trying to connect through the web. And I would like to be interactive. I would like to be hearing your doubts, your questions. You have a chat. You can use the chat and ask questions. And we would like to know if you have any doubts or comments. To be interactive from the beginning, I'd like to start asking you a couple, two or three questions at the beginning, just to have an idea of who are on the other side of the camera. This is very easy. You will have a cell phone by yourself. You take your cell phone and read the QR code you have there, or go to www.menti.com and you enter the code 81430580. With this, you will be able to answer the three questions we're going to make at the beginning and one more at the end, trying to involve all participants in this exciting topic of middle ear implants and bone conduction implants. So the first question is very easy. What is your field of expertise? You are surgeons, you are audiologists, you are engineers, you are nurses. What are the field in which you are spending your professional activity? And as usual, we see that audiologists are most of the people attending this session. We also have ENT otologists, but audiology is a main issue for those who are at the other side of the camera. And for you, we will try to be as practical as possible. So the second question, just to focus on the topic we will discuss today, is which challenges do you experience every day with hearing aid users that are treated with traditional solutions and are taking you to use middle ear implants or bone conduction implants? You are concerned about the short wearing times of patients with hearing aids. You are concerned about discomfort, stigma, poor outcomes, feedback, other issues that we have not been able to put in the slide. What are the main reasons for you to use middle ear implants or bone conduction implants? And we see that feedback and distortion followed by stigma are probably the most important issues. Discomfort and poor outcomes are also important problems with patients treated with conventional hearing aid solutions. So let me give you a last question, just to have an idea of those 4% answering others. What are the other challenges you have faced with patients using conventional hearing aids that take you to propose, to suggest the use of middle ear implants or bone conduction implants? You have those who answer other. What are these other problems you have with your patients using conventional hearing aids? And I don't see many answers. Not enough power, that may be an issue. Price, poor sound quality, low, high frequency gain. Okay, so it was only 4% saying others. So this is, the price becomes a real issue that we may also discuss. Feedback, wearing time are issues that we may discuss during these presentations. So once we have gone through this first interaction with the audience, I would like to start with the presentations. Presentations will be very short, will be very practical, and after the presentations, we will allow time enough for discussion. The first presentation takes us back to Vienna again with Professor Wolf-Dieter Baumgartner. Professor Baumgartner is the professor of otorhinolaryngology at the medical faculty of the Vienna University, and he's the head of the ENT department and senior physician at the Vienna ENT University Hospital. Recently, he has been elected as the new president of the Collegium Otorhinolaryngologic Mammacitia Sacrum. And Professor Baumgartner, as you could see at the beginning of this event, is the president, is the chairman of the hearing for the last 4 years. Professor Baumgartner will give us a short talk about the 25 years of experience of achievement with vibrant sound bridge. Please, Baumi.
Javier, thank you very much. Yeah, dear colleagues, it's a very special pleasure because all these 25 years of vibrant sound bridge are also my personal history. It's really unbelievable. And if we start now, if we start here in the year 2021, we see the recent vibrant sound bridge. So the implant we have right now with the Samba audio processor outside with the implant, it's a semi-implantable device for sensory neural loss, partially conductive loss, and we see an MRI compatible magnet, a demodulator, a conductor links. On the right side, you see the implantable part. You see the floating mass transducer of a side of 2.8 millimeter long with different clips. So this is the floating mass transducer. It is an additional power to the ossicular chain. So the vibrant sound bridge is an additional motor to help the ossicular chain to vibrate. The maximum gain of out power is in between 120 up to 140 dB of power of the device itself, but this is not the indication range. So the indication range is up to 70 dB at 1 kilohertz. And inside you see there is a magnet, and the miracle, although you have a magnet inside who is moving in between two rubber balls, the implant is fully MRI compatible. So this is what you have today in the year 2021, but it was not always like that. There was already 30 years ago a young man, Jeffrey Ball. He is the inventor of the system, and he was hearing impaired, and he said himself, I want to invent something to overcome my own hearing problem. And he invented this device. And because of regulatory problems of the FDA, the very first implantation was now exactly 25 years ago in June 1996 by Professor Hugo Fisch in the University Department in Zurich. And it was an implantation on the long process of the INCO. So this was the very first surgery. By the way, the second surgery was in Hanover at the Medizinische Hochschule in Hanover. In 1998, the device got the CE mark. This was a comprehensive work of different clinics. It was the University Clinic of Würzburg. In those days, Professor Jan Helms was the German, before Professor Hagen nowadays. It was Hanover, it was in Belgium, it was Vienna, it was in Lyon, and of course in Zurich. In 2000, I was personally involved into the FDA approval into this device, which was a very, very big step. And from these days on, it started in the United States as well with a higher number. Then in winter 2002 to 2003, the Austrian company Med-El took over the old Symphonics company. And since March 2003, the device is manufactured, delivered, and also all the research is done in Innsbruck and also here in Vienna. In the year 2005, Professor Vittorio Coletti introduced the round window placement, which was actually intended from the very beginning. In the original patent work from Jeffrey Ball, it was patented in the year 92. The floating mass transducer was intended to be on different stages in the middle ear, and Coletti was the very first person who did it in a real surgery. And then we had a comprehensive study also, most of the already named clinics, and we did the approval for mixed and the conductive hearing loss. Nevertheless, we had then the first digital audio processor in 2009, and also in 2009, finally we had the approval for children. This was very difficult because it was not so easy to get the approval for pediatric use. although we did the very first pediatric surgeries already in 2005, until we had the approval, I did already more than 12 pediatric surgeries, but these were always single case decisions. Then in 2010, the second generation couplers came up. The couplers have a better coupling to the different parts of the ossicular chain. Those were introduced at the German ENT Society meeting in May 2011 in Freiburg, and then 2014 in November in Rome by Robert Mlinsky. He's nowadays not in Würzburg anymore. He is now in Rostock, German, and he was the mastermind of the third generation couplers we have nowadays, and those couplers are still in use. And we have now the digital Samba audio processor, and of course with the new features and the connectivity to iPhone and also waterproof, we have the Samba 2 audio processor. So this is very, very nice. Just recently, not even 3 weeks ago, there's a very nice paper by the inventor, Jeffrey Ball, the design and development of the vibrant sound bridge after 25 years. And this is a really very big step. You see now the scientific development. These are the papers in the Medline, and you see up to 233 papers per year are in the Medline about the vibrant sound bridge. 3 years ago, Professor Barbara Wollenberg, now in Munich, and myself had the honor to make a paper out of 2,000 other papers, so a comprehensive paper, and this is now 3 years old. What can we say with the vibrant sound bridge implantable hearing aid? We have now proven long-term stability. In Vienna, we still have people with the fully working implant, and not only in Vienna, I think also in Würzburg or in Zurich or in Hanover or in other departments, people who were implanted 25 years ago, and they still have the original implant fully working in place. We have an extremely high hearing preservation rate. We have no change of the bone conduction thresholds in nearly 100% of patients. So if we make the survey in our own database, it's about 99% of patients. We have an implant survival rate of 99% after 5 years. So this is an implant which people really use, and they're really, really very happy. You see here the paper from us, from our group, but they are also from different groups, a lot of very nice papers, Burkhard Schwab, and also the colleagues from Bern, for example. But this was not only the only one thing. We did in Vienna 7 surgeries, vibrant sound bridge in local anesthesia, and could find out that the floating mass transducer, of course, had also bone conduction properties. And this led us directly in the year 2004. In the year 2004, the development of the bone bridge started. Jeffrey Ball and myself had the idea in Geneva, and we started the construction. But it took quite some years. It took until the year 2011, when Georg Sprinzl in Innsbruck implanted in summer, in June, exactly 10 years ago, the first bone bridge. And a year later, in March 2012, I had the honor in Vienna to do the very first pediatric implant with the bone bridge. And you see also the CE mark in 2014, I had the honor to use first time the bone bridge lifts, also the Samba, the full FDA approval, and 2 years ago, the new, smaller, but as well powerful bone bridge 602 implant, bone conduction implant. We will talk about the bone bridge also a little bit later, maybe also in the discussion, and also with the fully connectivity of the Samba 2 processor. This is the very short comprehension, and I hope it was not too much information and you enjoyed it. Thank you very much.
Thank you, Baumi. It was great. You provide a lot of food for discussion after the presentations. And now let's move to the next speaker, which is Professor Georg Matthias Sprinzl. He's the head of the clinical ENT department at the St. Pölten University Clinic. Georg has extensive experience on several thousand surgeries, and he's an internationally renowned lecturer and guest surgeon. Hearing is delighted to have Professor Springsel as one of our distinguished members.
Oh. Javier, thank you very much for the introduction. And I will give you a short overview about the scientific stuff we did the past 10 years. We'll give you a short overview about the scientific stuff we did also the last 10 years. And by the way, the magic words on this slide is long-term. So as Professor Baumgartner before mentioned already, we have over the past 25 years an extensive experience with the vibrant sound bridge, and in the meantime for 10 years also an extensive experience with active middle ear implants. And we picked 3 of our papers, which I will introduce very shortly. By the way, I would like to point out that over the past 14 years, I did over 350 vibrant sound bridge surgeries, but the very first one I did with my friend Wolfgang Baumgartner, and I'm still grateful to him because he visited me at that time in Germany, in Marburg, where I worked for 1 year and helped me during my very first surgery. So Baumi, thank you very much for that. Next slide, please. You go on. No movement? Yes. Recently, we published our paper about long-term stability and safety of the sound bridge coupled to the round window. I would like to point out Professor Coletti, who taught me in the year 2011 when I visited him. And it was a very nice visit at that time in Verona. And he showed me his personal technique, how to place the FMT onto the round window. Over the past years here in St. Pölten, and I'm working here since 2013, we did a couple of surgeries, and we have, of course, already also long-term results in those 46 subjects. So we could see that we have no change of residual hearing over time in those patients. A lot of patients are wearing their vibrant sound bridge, the audio processor, over 13 hours a day. And we like to point out that the vibrant sound bridge coupled to the round window is a really stable and safe also in terms of long-term results. Next, please. Of course, we checked also our patients which received coupling on the ossicular chain. And as we have heard so far, we have also some modifications with some couplers. So in the meantime, since 2014, we have also the short process couplers available. And you can see here on those plots the different options of placing the FMT on the ossicular chain. On the one side, on the left side, with the short process coupler, where the coupler is placed on the short process of the incus, and on the other side, the more classical approach with the long process coupler. And also the long process coupler was modified with clips and was refined in the last years. Next, please. So we could study the effectiveness in 77 patients, and we could point out that we have a device survival of 100%, and all of our patients had a significant audiological improvement with both short process and long process couplers. And of course, it has to be pointed out that we also have seen a large improvement of quality of life. Next, please. Next. Yes, now I would like to switch to the transcutaneous active middle ear implant in children and adolescents. Also here we have a long-term multi-center study in performance of treated with the vibrant sound bridge. Also this paper points out that it's a safe and effective treatment. We had no pediatric specific safety issues and significant audiological improvement, very stable results. And you can see here on the right side, the improved work recognition scores comparing preoperative and the postoperative situation in those patient groups. Next one, please. What I show you here right now is our hearing graph. And with that visualization, you can see on one hand the improvement of the intervention, comparing the unaided free field situation and the aided free field situation. Go on. And we are adding to this information also the varying time of the audio processor. So you see not just the pure tone average, which is improved, but you see also the duration of the varying time. And with that hearing graph, you are able to see at one glance all the potential benefits of the intervention which we did over the years. Next one, please. Finally, I would like to point out also our experience with the active transcutaneous bone conduction device. So we did here a systematic review, and we could find 39 publications which were liable for the analysis, altogether 487 subjects in total, 303 conductive hearing losses, 67 mixed hearing losses, and 53 cases of single-sided deafness. And we could find that the overall mean functional gain was about 32.7 decibel. And this is a large functional gain, which highlights also the power of the device. Next, please. This is going back to the historical first implantation which we had with my team at that time. From left to right, Johannes Schnabel, Astrid Magele, and of course, Victor Kochi. So with that team, we did our first implantation on the 6th of June, 2011. Definitely a date for us which changed our life and many lives after all. The work recognition score improvement is about 50%, which is also a very high number. And this number is significant for a lot of studies. I would like to point out also one study of Luis La Saleta, who will give a short talk later on as well. Next, please. Well, this is also historical. And we were younger at the time. This was at the meeting in Amsterdam when we launched the first results of the bone bridge. In our analysis, we could analyze also all reported adverse events. And we were looking at the sum person years reported. And this is a very high number, which means a high number means low major adverse events for the people. So it's a very safe and good device. And I like to point out that almost 91% showed no complications at all, and just 1.7 major complications and 7.7% minor complication, minor adverse events in the study which we conducted. Next, please. And that's it. Thank you for the moment.
Thank you very much, Jörg. It was a great presentation. And now I would like to ask the online managers to take us to Madrid. I'm in Madrid, but for those who are away from the city, let's make a trip to Madrid. Great, thank you very much. This trip takes us to my colleague and friend, Luis La Saleta. Professor La Saleta has to suffer me for more than 20 years, and even he had to suffer my person for that long time. He looks like a happy person. He's the head of otology at the Department of ENT at La Paz University Hospital. He's associate professor at the Autonomous University of Madrid, and he's involved also in politics, in professional politics, as the president of the board of otology at the Spanish Society of Otolaryngology. In hearing, we are pleased to have Luis La Saleta as one of our distinguished members. And Luis will give us a short lecture about the need to have a middle ear implant. Why do we need a middle ear implant, Luis?
Okay, good afternoon, everybody. Thank you very much, Javier, for your nice introduction. In the next 4 or 5 minutes, I will try to answer this question. Why do we need a middle ear implant? Well, as otologic surgeons, we have to face a lot of patients with conductive or mixed hearing loss, suffering from different conditions. Sometimes these patients had favorable conditions. This means they have stable, dry ears, and in this situation, they are good candidates for the traditional options, which are middle ear reconstruction. Here we can see a very nice picture of a TORP, or hearing aids. That happens quite often. But we also see a lot of patients which have unfavorable conditions for middle ear reconstruction or hearing aids. And we all know that these traditional options won't give us good outcomes, especially in the long term. So which are these conditions? Well, I would think about 4 conditions or 4 groups of conditions. The first one would be chronic ears, sometimes active, with no ossicular remnants, mainly open cavities with large meatoplasties. In these cases, we know that ossicular reconstruction won't give us good outcomes, and it's nearly impossible to fit correctly a normal hearing aid. The second situation would be a subtotal petrosectomy. This is a surgical technique we can use for several conditions. It can be used following surgery for paragangliomas, for chronic ears. It can be used also for CSF leaks. In this situation, we cannot fit a hearing aid because the external auditory canal is closed and we don't have a normal middle ear. The third situation would be advanced otosclerosis. So we have some patients with otosclerosis when sapedectomy and or a hearing aid cannot offer enough gain, but still the patient is not a good candidate for a cochlear implant. And fourth, we have some patients with external or middle ear malformations in which ossicular reconstruction is nearly impossible or won't lead to good outcomes. And fitting a conventional hearing aid, it's just impossible because there's no external auditory canal. And moreover, these patients are not good candidates for a bone conduction device, which is normally the preferred option for these cases. Okay, so in these 4 groups of conditions, a middle ear implant would be a nice alternative. Why? Because on one hand, we can bypass the middle ear, and on the second hand, we can directly stimulate the inner ear. So we can compensate both the conductive and sensory neural component of the hearing loss. Here on the right, you can see a nice example of an FMT placed on the round window, what is called the round window vibroplasty. Then we have a completely different scenario. Those patients with sensory neural hearing loss, in which we cannot fit a conventional hearing aid for different reasons, but mainly because of chronic conditions of the sternal auditory canal. Again, in these cases, a middle ear implant is a very good alternative. My preferred option would be to place, in this case, the FMT on the short process or the body incus, as you can see here on this picture on the right side. So, to sum up, why do we need a middle ear implant? Because there are certain patients with either mixed or conductive hearing loss or sensory neural hearing loss, in which the traditional reconstructive surgery of our hearing aids won't give us good outcomes on the long term. So In each particular case, we'll have to choose the best location for the FMT and to choose the best coupler. But that's the reason we need a middle ear implant. So Javier, I hope I shortly answered your question. Thank you very much.
Thanks, Luis. That was great, clear, practical, concise. So guys, can you please take me back to Vienna? I want to meet again Baumi.
Muchas
Hi, Baumi.
gracias.
Hello again.
Yes, thank you.
Can you tell me if bone bridge is the ideal solution for children?
I tried to answer, but in many cases, yes, it is. But we will discuss this. But now, yeah, I want to continue the bone bridge story, because you should not forget the construction of the bone bridge started in May 2004. That was exactly a year before Professor Vittorio Coletti started the round window approach with the vibrant sound bridge. So we had already, since Medel took over the Symphonics company in 2003, exactly since that time, we had already ideas with a lot of experiments to make the floating mass transducer bigger. So first the idea was to make a bigger FMT, but this was not so easy to place into the middle ear. And then finally, Jeffrey had the idea to make a, let's say, bone capsule to have the FMT into this bone capsule. And this was actually the idea for the bone bridge. And I asked him, look, when should we do the first surgery? And he said, okay, in August. And I already reserved surgical place in August 2004 for the first bone bridge surgeries. But then, as we all know, it took a bit longer. And then Georg Sprenzel did it in 2011. So it took another 7 years. So constructing an implant is not such an easy task. But for the children, it was very big thing. So all our bone bridge kids, and in the meantime, this is really a lot of children. It's a quite big 2-digit number. And 100% of those kids have an atresia and malformation. And we should not forget the bone bridge is very convenient in difficult anatomical situations. It's not so easy to place a vibrant sound bridge in a Jasdorfer scale 3-4 child age 3-4 years old. So these are really very demanding surgeries with a long surgical time, quite a risk, and those surgeries are definitely not for any surgeon. So the bone bridge was really a very, very big step, since we introduced additionally the lifts, and now with the new bone bridge, with the 602 bone bridge, which is only 4 millimeters, we are already in the old Baha range. So the old outdated Baha from the 70s had for kids 3 and 4 millimeter screws. And this is exactly the range where the recent bone bridge is, with 4 millimeters plus a 1 millimeter lift. We are only in the 3 millimeter area, and also for smaller ears, this is definitely to use. So we have already, with the 602 bone bridge, which is 1.5 Tesla MR compatible, a very reliable implant, not only with an intact skin, with a healthy skin. It's not only intact, it's healthy. It's a completely healthy skin. It's a healthy kid. It's secured very nice. I have young children implanted 5-6 years ago, now adolescent, who have very intensive sport. So some of them are sportsmen in soccer team. I mean, really in youth professional sport. And the surgical flexibility is really a very big tool. Additionally, now with the kids, with the Samba 2, they have no stigma anymore. So the new audio processor is not the stigma, actually it's fun. And we have seen already in some classrooms in Vienna that also non-hearing impaired, so normal hearing kids, wanted to have some of those stickers, like the monster or the princess. So the Samba, which is also reliable for the FM devices in school and which is water resistant to 1.5 meters depth. This was really a very big step forward. So nowadays, I think in pediatric surgery, the bone bridge is definitely a very good tool and nice to use. Thank you very much.
Great, Bami. I was clear also. And now, to finish with our presentation before discussion, we will give you the fastest trip you have ever had to Australia. And I promise no jet lag. And we came to Australia to meet Roberta Marino in Perth. Roberta is a senior audiologist at the Fiona Stanley Hospital. Her areas of expertise in the field of hearing loss are implantable hearing devices, including cochlear implant, middle ear implants, and bone conduction implants. So she's the best person to speak to a large audience of audiologists about the problems related to middle ear and bone conduction implants. She's also a well-known expert on vestibular and electrophysiological assessment. In hearing, we are very pleased to have her as one of our members. Please, Roberta, can you tell us why do we need a middle ear or a bone conduction implant, not from the surgeon's perspective, but from the audiologist's perspective?
Thank you, Javier. And I have to apologize. I think there will be a maybe 2-second delay with me talking and my voice coming through. But I just Googled that I'm 13,500 kilometers away. So a little bit of delay is not too bad. So firstly, the first indication is when we're looking at sensorineural hearing losses. Why would we consider, oh, sorry, hang on, one up. Okay, sorry. Why would we consider a vibrant sound bridge above a conventional hearing aid? And as Luis mentioned, if there's any pathology in the external ear canal, it can be very difficult to wear a conventional ear mold. And also something from an audiological point of view, and it came up in the survey as other, but and as a power limitation. But there's so much gain needed in the high frequencies for hearing loss like this that it can be prone to getting feedback. And you have to have a very closed fitting so you don't get feedback. And some people really do not benefit from a closed fitting because of a medical condition. So a hearing aid or amplification option where there's nothing in the ear canal is very desirable. For people with stenotic or misshapen or narrow canals, having nothing in the ear canal is a great benefit. It allows for greater usage and comfortable usage. Stigma can be an issue with some hearing aids, whereas a processor like the Vibrant Sound Bridge or the bone, even the Samba 2 is very discreet and worn under the skin. Some studies have actually even shown that speech perception with a middle ear implant for a sensorineural hearing application has given better results. And you've got the list of references there as well. And tinnitus, this is something we were interested back in 2013, and it's an area of interest of mine, but we find that people who have tinnitus, the more occluded their ear canal is, the less benefit they get from amplification. So in a way, having an open fit option where there's just the external processor worn could be a very good option for people with tinnitus. And there's a really nice study to a young et al. In 2015, and they found that people wearing the VSB for their sensorineural hearing loss had a 91% of them had a reduction in their tinnitus. And then we go on to the next application, which is why do we need a middle ear implant for mixed hearing loss? As audiologists, we look at these hearing losses and we just realize how much gain is required. It's really significant. It's very hard to overcome that conductive component without getting feedback or distortion. So that's something that's really bypassed with the FMT sitting either on the ossicles or the round window. When you can bypass this conductive component, we did a study back in 2013 comparing hearing aids or conventional hearing aid performance with that of the VSB for mixed and conductive losses. And we found people did better in noise. There's a study by Iwasaki that found that patients also did better in quiet with this application. Again, there's no ear mold occluding the canal, increased comfort. And in our group of patients with the VSB, every one of them who had tinnitus had a reduction in their tinnitus, and 66% of them had tinnitus reduced to non-significant levels. So it was a really effective form of tinnitus suppression. And this continues today. I think there's only one patient I've seen personally that has not had a reduction in tinnitus with wearing VSB. And then why do we need a bone conduction implant? And De Wolf in 2013 showed that both the conventional percutaneous devices, and this could extend to the bone bridge, could give better performance than a hearing aid if the air bone gap is greater than 35 decibels, and that's with their speech recognition scores. The issue with percutaneous solutions is that the risk of skin infections and complications. Here in Australia, this is going back a few years, but we had infection rates and complication rates of 38%. It's a bit unfair. We have a hot climate. This has been reduced now with some new techniques to around 10%, but it still doesn't compare as well to what you can get with the bone bridge, where there's nothing, abutting out of the skin. Complications can be worse with the percutaneous device in children, and the higher profile of the implanted processor makes it more prone to being hit or damaged. An advantage of percutaneous devices, though, is that you can have a bit more power, and also their artifact on MRI is smaller. But I know that they're in Madrid, you're doing some work. I read a really nice blog about your work with looking at the positioning of the implant and also reducing it with different sequences. And just with the bone conduction implant, Vibrant in 2020 produced a nice white paper looking at complication rates. And just a quick summary, because I know I don't have much time, but it was over 1,000 papers investigated, and then 27 papers were highlighted that had good feedback on complications. So for just looking at it as a 6-month average, and we're looking at the light green bar as minor complications, and that could be things like infections or skin irritations, and then more major and sequelae. If there's anything that's going to occur, it will be most of the time in the first 6 months, but it's quite a low number. And then from then on, the numbers are very low in terms of complication rates. And the final part is, and this is a bit tricky, like when you have an option, when a patient could meet the criteria for both a VSB and a bone conduction implant, what do you choose? And some of the things that we consider is that there's a wider fitting range and greater high frequency gain with the VSB. And for patients over 60, just normal age-related hearing loss means that they will have probably a 1 decibel hearing loss per year. And so the bone bridge has a smaller fitting range, so that's just something to consider. With the Vibrant Sound Bridge, we often find that we get ADA thresholds that are better than the bone conduction thresholds, which is called overclosure. And general bone bridge and other bone conduction devices, you get ADA thresholds that equal the bone conduction thresholds. We also found that if with the Vibrant Sound Bridge round window, this is comparing it to the Baha, if the bone conduction thresholds are greater than 35 dB, then people will do better with the VSB application. And these results were also very similar in the Fuchs study in 2018. Maybe for the VSB, just stimulating one side is better for asymmetric losses, I'm not sure, but maybe the bone bridge is more cost effective. You get 2 cochlear stimulators for the price of 1. Localization, very mixed results for VSB compared to bone bridge, and that's often a topic we think if you stimulate just the one cochlea, you might have better localization. But we ourselves have very mixed results, and this is also in the literature. And then, as Balmi said, the anatomy sometimes can preclude some people from having the VSB, and the bone bridge is a simpler option surgically. So thank you. That's it from me.
Well, thank you very much, Roberta. That was clear. And I appreciate you being all of you on time, so that give us a bit more than 30 minutes for discussion. So let's start the open discussion. And I would like to be polite and start with the lady. And I will start, Roberta, with your last slide. You try to summarize why bone bridge or why sound bridge, why middle ear or why bone conduction. But can you try to be a bit more specific, a bit more practical in your daily life, in which cases you prefer sound bridge or middle ear implants, and in which cases you prefer bone conduction implants?
I think the fitting range for me is a big indicator. So if they have very good bone conduction, then it could be both. However, if the hearing is on the borderline, or we could see that there's a history of some progressive nature to the hearing loss, even though that's not ideal to have that person implanted with a middle ear implant, then the vibrant sound bridge might be a better option. If they're older as well, just because they will get age-related hearing loss. So if there's already a sensorineural component there, and then that could fall even further, I think we need to be really mindful of that. And the anatomy. So I think actually the surgical part of it is a big factor. And this is, I am not a surgeon, but from my point of view, if FMT could be fixed onto part of the ossicular chain, and it's more stable, especially in very complicated ears, I think that could be a better option to have that than a bone bridge. But if there's a lot of anatomical problems or a round window approach is the only option, then maybe the bone bridge is better. But yeah, localization, outcomes, we're finding it's very hit and miss. Some people we think will do really well localization wise and they don't, and vice versa. So I know I'm not very helpful, but I think both are good options. But if you have a worse hearing loss, go VSB, and if your hearing's likely to deteriorate, VSB.
Great, Roberta. We have a distinguished guest among us that wants to say something. Professor Hagen, can you tell us what you think?
Yes, first of all, congratulations to all of the speakers. Very interesting and nice, and especially short speeches. One goal of the hearing is to have an internationalization. That means also to improve the numbers of middle ear implants and bone bridge all over the world. So what are the impediments to have this technology also in the third world? What do you think, to all of the speakers? Is it the aftercare? Is it the need of surgery? What do you mean, all of the speakers? How can we improve the technology to bring it into third world countries?
What do you think about that?
Yeah, so this is very personal from my side, because I just have now recent experience with some colleagues, let's say from the African continent. And for me as a surgeon, I think it's really at the moment, really a surgical problem. If you think for countries, for example, in Uganda, you have 6 ENT doctors. I would not call ENT surgeons. You have 6 ENT doctors in the whole country. You have countries in Africa, for example, they do not have a public MRI in the health system available. So I think it's not only the conventional hearing aids, it's also a surgical thing. And especially for the surgical thing, the bone bridge is of course an easier surgery. So it was, I think, for the economical survival of the system itself, an important step to go from the sound bridge to the bone bridge. Because if you look, how many surgeons do you have who can do a vibrant sound bridge? So there are certainly, it's a 3-digit number, but if you have how many surgeons can do a bone bridge surgery, of course, it's a 5 or 6-digit number. So this is a very, very big difference.
Okay, but we have, we have two options. We all know that sound bridge is difficult to place because surgery is complex. Now we can move to other solutions, or we can try to improve the way sound bridge is applied, or the next generation middle ear implant is applied. Is there any option that we develop something that is easier to use? Georg?
Well, so coming back to the question of Professor Hagen, I think in the third world we have, of course, other medical problems. Basically, we need to control infectious diseases there. And I think hearing implants definitely in the second line there. This can change, of course, in the future, but at the moment, I think this is the biggest problem. And then, of course, I fully agree with Wolf-Dieter Baumgartner. We have also some surgical issues. We all know vibrant sound bridge surgery can be very tricky, especially when you do it in cases with middle ear pathologies, cholesteatomas, and so on. This can be very demanding surgery, and of course, this is not so straightforward. So I think vibrant sound bridge surgery is reserved more or less for more developed countries where you have good maintenance, where you have good care of those patients, and I think this is not so easy to accomplish. For bone bridge surgery, of course, surgery is much more straightforward. But nevertheless, we need to take care of the external part of the device. So you need to take care also of the fitting of the patients. I think in the third world, we have still a lot of problems around those cases. And so
good, Luis.
Basically, I think this will be in the future also a challenge for us.
Great.
Yes, I absolutely agree. I just wanted to add that this controversy of choosing between bone bridge and sound bridge, we have to see it with some time. I mean, if we look back 12 or 13 years ago, at that time, maybe we chose the vibrant, the sound bridge, because we didn't have a transcutaneous alternative for a bone conduction implant. So now I believe that the reason we are not implanting more and more cases of sound bridge is because, as Roberta said, we have to think about this solution for mixed hearing loss, because most of the cases of pure conductive hearing loss, we can solve them with an easier solution, which would be the bone bridge.
Okay, we have Professor Hagen and then Professor Prinzl. Rudolf, please.
Of course, this was a question to all of the participants, also to Roberta Marino. Thinking about surgery, you can send on a regular basis surgical teams to third world countries. This would not be a problem if you have some partner universities. We can arrange by the hearing to send a surgical team if the indication is already done. What do you think about the quality in audiology in the third world countries and about the possibilities of aftercare after implantation, Roberta?
Okay, you answer, Roberta, and then we give the word to Professor Prinzl.
Because the processor and the programming, it's not exactly the same, but it's very similar to fitting a conventional hearing aid. And in fact, the chip, it comes, from a company that makes conventional hearing aid. And so if someone or a clinic has experience fitting hearing aids, that would be very useful. I think they could be guided. We haven't done any remote programming with the vibrant sound bridge or bone bridge. We do a lot with cochlear implants because we have people living in remote locations here in Perth. But if there was a way we could do remote programming to assist for more complicated cases, maybe having meetings where surgeons, radiologists, audiologists, speech pathologists if needed, could discuss complex cases online. It's a possibility. There could be some challenges that could be overcome.
Okay, Georg.
Well, just one final remark from my point of view. So I think we are all very romantic people, and we have our view as doctors and surgeons. At the end of the day, in the third world, people are starving, and still we have people losing people from hunger. And money talks, you know. We have to finance also the implants, and implants still are quite expensive. And also the surgery is expensive, so the whole package is not so easy to accomplish. And we shouldn't forget about that as well.
But you can have a foundation, for example,
but
a foundation
general,
to solve a problem.
Scale, you know. So when you I think this is one of the problems.
You can think about starving, but there are many people who had a really profit from the hearing implants in the third world countries too.
Definitely.
Okay, let's move to another. I have a question from the audience. Let's move to a practical issue. I had this question also in my list, and it concerns sound bridge in the wrong window. And I am asking you, Luis, because we had this issue before, and we still have this issue. The question is, how do you make sure that you get the best coupling result? So can you tell us, and then the others, if you want, tell us, how do we know? Because when you put a long process of the incus coupler, you know that this is there and it will be staying there. But when you put something in the round window, how do you make sure that this is the best solution you can get?
Well, that's a tricky question. I think the short answer would be surgical experience, because if you are an experienced surgeon, you'll know if that will work or not. But sometimes you need some feedback. That feedback can be just maybe if you have a mobile foot plate and you press the FMT on the round window, you can see the movement on the foot plate. Sometimes you might not see the foot plate very well, and then there comes the issue of the intraoperative measurements. So long time ago, we did some intraoperative measurements with electrocochleography. Now there's a new system with evoked potentials. That's also useful, but the thing is that, especially in these cases we are talking about of mixed hearing loss, you need to have a perfect coupling to have the best outcome. So I believe there's not an only way. I mean, I won't say you need this kind of coupler, or you should put the FMT just on this way, with or without cartilage, with or without fascia. There are several ways to do it, but you need to have a really good coupling, especially when the sensorineural component is large.
Some other ideas from Professor Baumgartner, Professor Sprinzel, from surgical standpoint?
So the round window coupling sounds easier as it is surgically. We must not forget that the anatomy of the round window is very, very different. And it's completely different in a regular anatomy to a malformation. One of the tricks I want to tell you is, I use both rubber balls from the round window coupler. So I use the one rubber part directly onto the round window. So first of all, you need to expose the round window very nicely, that you can make the round window test. This is very important, that you really see that the window is moving. And then you place the half rubber ball you put in, and on the contralateral side, I try to support it at some bone crest. And this works very nice. Surprisingly, in the long run, once the first year is survived by this round window placement, it will hold more or less forever. So I've never seen any problem after 1 year. So if there is a problem, then it is in the first year. And then at the end, the stability is surprisingly good. But what we are still missing, of course, I want to say, is a really objective measurement. What we tried intraoperatively and also in tests intraoperative or on cadavers laser Doppler measurement. But even with the laser Doppler, if you have good coupling, you cannot be sure that the patient will have good coupling, because you still have this psychophysics of hearing. So it's a very special point if the patient has a metal hearing or a clear hearing. So this it's very tricky, actually. Yes.
Okay, the question that was made by the audience has a second part, and I would like you to have a short, very short answer, especially the surgeons, because it is a surgical question. How often do you see a loss of inner ear after a round window placement of VSB?
May I add at last one thing to the coupling, Javier?
Sure, of course.
Now we have in all sound bridge surgeries an intraoperative monitoring in all cases. It was developed by our audiologist, experimental audiologist Mario Cepula, and it was already published. And there's a nice video, maybe I also in the hearing website. That helps extremely. As a surgeon, we had it during our surgical course. There was a case I could not directly watch the foot plate. I could palpate it, and I put the oval window coupler, and immediately he told me, you have a perfect coupling. That's the same with the round window, and you do it after insertion of your coupling and at the end of surgery. And this is extremely reliable. So it is standard in our department, and I can only encourage other colleagues to use this system because this helps a lot. Thanks.
Thank you, Rudolf. Now, Georg, percentage number of loss of the inner ear in round window coupling. Short question, short answer.
0.
0. Luis?
0 so far.
Baumi?
Not a single one in 68 cases. 0.
Okay. I'm an old guy, and when a surgeon has no complication, it's because he has not enough cases. But the percentage looks to be really, really small. Now, can you tell me just one, which is your favorite coupler? Georg?
My favorite coupler for round window surgery? Or
No, for sound bridge, VSB.
So, honestly, I like to use the new long process small clip coupler. So the very slim one, long process, yes.
Long process,
but
Baumi.
To be honest, I use the short process coupler also in selected cases.
Okay.
I'm using it, definitely.
Baumi.
I hope nobody from any company will kill me. I like most the old Symphonics coupler.
The clip, you mean?
Yes.
Okay, good. I agree with you, but don't tell them. And Luis?
Yeah. I was thinking exactly the same as Baumi, but of the nowadays couplers, the short process.
The short process. Good. Roberta, you mentioned something about tinnitus and sound bridge. May bone bridge improve tinnitus in single-sided deafness?
In single-sided deafness. I don't know. I know there's a paper on that, but I personally have not had that experience. So we have a few people who have bone bridge for single-sided deafness and who have tinnitus. Some of them could have had a cochlear implant, but they opted for a bone bridge. There's not that many. I can probably think 4 or 5 offhand. None of them had a reduction of tinnitus. And do you mean single-sided deafness, that there's complete sensorineural hearing loss, or that there's still some bone conduction?
Sorry?
I'm wondering if your question is for people who have a complete sensorineural hearing loss.
Yes, well,
on the deaf side.
The patient where we use bone bridge with sensorineural hearing loss is only those with single-sided deafness, because the others, the level of bone conduction will not be useful.
Yeah. So if there's tinnitus for what I've seen, if the tinnitus is in the poor, the non-functioning ear, no, I haven't seen any reduction in tinnitus.
Okay, and now, well, I can, and this is a question, but I will tell you my doubt. It's a personal doubt. I can understand a bilateral sound bridge. You specifically stimulate one side of the ear, each ear separate. But can you tell me, all of you, your opinion about bilateral bone conduction devices? Baumi, you were smiling.
Yeah, the surprising thing is we really have a lot of them. We actually, in the old Baha times, 21 years ago, 2000, I did already bilateral Baha with the screw. And then for me, it was completely clear that we do bilateral sound bridge. And then it was for me completely clear to do bilateral bone bridge. And of course, I know the so known physiology of the bone conduction as we know it in parts, but a matter of fact is that the bilateral bone bridge patients do very well. And they have, Viktor Kocic showed this already many years ago, and they have spatial hearing, so they have directional hearing. Also our patients have that, and those who have bilateral sound bridge are very happy people.
Luis, do you have bilateral sound bridge, the bilateral bone bridge or Bahas?
No, not at all. I mean, there's an economical issue too with this kind of implants. So due to that reason, we have no bilateral cases. But I understand your doubts from the physiology point of view.
And Georg, you have concerning bone bridge, bone conduction, Baha, bone bridge.
Yes, so we have bilateral patients, and it's working well. So it's a question of to have a good audiologist, and he's fitting them, so this works very nicely. Indeed, we have also some combinations between vibrant sound bridge on the one side and bone bridge on the other side, and this works also in the same way. Mm-hmm. So in terms of audiologic results, they're quite similar.
Mm-hmm. Okay, Roberta, you heard the surgeons. It's working well. It's a very scientific approach to the problem. Now, can you give us a more scientific approach to the problem? Can you tell me, can you explain me, because personally, I don't have, Luis mentioned that we don't have bilateral bone bridge, because I don't see any advantage, physiological advantage, real advantage from a bilateral bone bridge. Can you correct me and show me how am I wrong?
Yeah, we don't have, we have the option of having it. We don't have that many, but I just saw someone yesterday. She actually had percutaneous devices first, had lots of infections, then was reimplanted with bilateral or binaural bone bridges. And so looking at speech perception, hearing in noise, even localization, she does better with two. I know it doesn't make sense with this, contralateral stimulation, but it really helps her. You can see it very clearly. So if there's no cost barrier, I think there's definitely a good incentive to consider too.
Okay, you don't have patients, any of you have patients with bilateral bone bridge or Baha who are not satisfied with the input from both sides and no, okay.
No, but Javier, can I just mention one physiological fact? I thought myself as well, how can it be that the bilateral bone bridge patients do so well? So one explanation might be that still the cochlea on the ipsilateral side, so on the side where the bone bridge, the implant is still the closer cochlea. If you think the diameter of the skull might be about 33 or 30 millimeters. And our brain can differ sound and noise of 0.1 milliseconds, maybe even less. We don't know that, but it's definitely 1.1 millisecond. And that's 0.1 millisecond is about 33 centimeters. So I think it's quite obvious from the pure physiology, from the physical data, that the brain can differ just by the measurement of the time difference, right and left. And this works also in the regular sound, in the air sound. Yeah? So it also works, of course, in the bone conductive sound.
Good. Thank you very much, Momi. Is Professor Hagen still there?
Yes.
Rudolf, we have a question from the audience to your mention of ABR-based measurements for monitoring VSB coupling. Can you please comment on the time needed for good measurements and how artifacts are rejected or eliminated?
I'm not an audiologist, but the inventor and Mario Cebulla, he developed a special stimulus for ABR. This is a so-called chirp, VSB chirp stimulus, which is absolutely reliable. They need 5 minutes before surgery to prepare their system, and during surgery maybe 2 to 3 minutes to get the feedback. It's very, very quick, and everybody who is interested can send me an email, and we can offer the video on the technique. It's also in English, and maybe then the people can get an idea how it works.
Great. Yes, Luis.
Just to comment on that, we are using the same technique inspired on Professor Hagen team. Just to make it clear, before electrocardiography consisted of a stimulation through the vibrant sound bridge to the FMT and recording from an electrode placed on the cochlea. And this new system is stimulation through the FMT, but you record from electrodes as it would be another brain potentials. Right. The thing is that we have had very reliable measurements when placement for sensorineural hearing loss on the incus, but still on the run window, I mean, there's such a variation on the bone conduction threshold and the anatomy and how the coupling is made that at this point, I think we're still on the learning curve, but it really looks very promising.
Okay, great. We are in a moment that I would like to get the audience involved in our discussion. I said that I wanted people to participate, and those of you who are sleeping, just wake up. And let me ask you one last question for the Mentimeter. We are now discussing about research, about new methods, about the ABR measurements, intra-op measurements for VSB. So go back to your Mentimeter, go back to www.menti.com, or just take your camera and take an image of the QR code. And we will like to ask you something concerning the future. You have been listening to the discussion about middle ear implants and bone conduction implants for nearly an hour and a half. And in this field, for those of you who are really interested in middle ear implants and bone conduction implants, which are the research you are most looking forward to see? What are the things that you would like to see in the future? A fully implantable or a Bluetooth system? And okay, this is simplify the systems. I don't know exactly what simplify means, but I understand that to make them less complicated from the surgical standpoint, because I think technology is not that complex. No age limit. What else would you like research to deal with in the field of middle ear implants, as well as bone conduction implants? Improve adherence, that means improve adhesive bone conduction devices, more connectivity, no age limit, improve adherence, intraoperative measurements, that's what we were discussing now, more powerful VSB, usability, connectivity. Well, these are ideas for research, for development, and they are coming and coming, and the indication range, increase the indication range. This is a good one. and better connectivity. Connectivity becomes a big issue for people in the audience. Okay, good. I think we have an idea of what the people want. And Rudolf, people are asking if they can have your email. I don't know if this is available or not through the chat, or
you can have it on the website of our clinic.
On the website of Professor Hagen's clinic. Now, let me ask you, we have still 5 minutes. Let me ask you something that becomes a scientific, a medical, ethical problem. I don't know in other countries. In our country, hearing aids are not covered by the Social Security. So patients have to pay hearing aids. I'm talking about sensorineural hearing loss, right? Patients with sensorineural hearing loss, they have to pay to have a hearing aid. But they can get free a vibrant sound bridge. You all mentioned that the indication for vibrant sound bridge were non-tolerance, problem with the external ear canal, economic issues, or dislike of the result of a hearing aid are ethically acceptable as an indication for BSV?
No.
No, no.
No.
So patients not paying for a vibrant for a hearing aid, they should be non-hearing instead of getting a vibrant sound bridge. That's the conclusion. Yes.
So Javi, sorry to interrupt. So this is very important. I had the discussion, or actually those thoughts, with insurance company representatives 20 years ago, when we started to bring in the vibrant sound bridge into the Austrian medical catalog. And the important point is a vibrant sound bridge or a bone bridge is not a fashion device. It's not a fashion device instead of a classic conventional hearing aid. A vibrant sound bridge and a bone bridge is a specific medical tool with a clear specific indication. And for those people who need it, it should be present and free, but it's not for people who didn't want or cannot afford a conventional hearing aid. This is complete bullshit. And just to go back to the data, in Austria, the hearing aid representatives, they sell 72,000 conventional hearing aids a year. And Georg and me together, we make about 65 implantable hearing aids together. This is 99.9% of the market in Austria. So you see, it's really a very big difference. And the payers in the system definitely must not be afraid.
Great. Thank you, Baumi. And you saw the word cloud we had with the last question. And I miss, well, maybe it was there, but it was not big. I miss 3 letters, MRI. You have been dealing with MRI. I think Roberta mentioned something and you all mentioned something. But Luis, you have some experience on MRI and bone bridge, mainly bone bridge, because one of the indications of bone bridge are problems with skull-based tumors, patients that need repetitive MRI. So I think it was Roberta mentioning that this can be improved with some sequences. Can you tell us something about, or can you tell the audience something about MRI and hearing devices like needle ear and bone conduction?
Yes, I think it's great that we are talking about devices that are both MRI compatible. But having said that, we have to remember that MRI compatible doesn't mean no artifact. So in these patients you mentioned, especially patients followed because of vestibular schwannoma, now we see that with certain placements of the bone bridge, especially in the middle fossa, you can reduce the artifact, and if the radiologist use certain sequences, you can even see the internal auditory canal of the ipsilateral placement of the bone bridge. So I think that's a great news, because all of us will need MRI at least once on our lives.
Okay, well, I have like 500 more questions, and less than 500 seconds to finish. So I would like to thank you, the four of you, for being so clear, for being so expert on the field. I think you have solved a lot of issues. People would be able to contact you if they need something. And with this, I would like just to give the final comments. I think we are dealing with a very, very exciting topic, with a very useful from a practical standpoint. If you have any doubts, if you want to know more about hearing, you have here our email address, our webpage. It's www.hearing.com, and you can contact us. We will always be willing to answer your questions and in trying to solve your doubts. And we will continue with our roundtables. We had two before this one. This is the third one, and the next one will be in autumn, and the other one will be in winter, 30th of September and 2nd of December. Topics will be announced on due time, and we are also preparing, without dates already, we are also preparing two more new roundtables for the coming year. And with this, I would like just to thank the online managers that made possible this technological connection between Australia, Austria, Madrid, and the rest of the world, all over your countries. And thank you for being there. If it was not for you, this would not have been needed or possible. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.